Excellent, thank you. So, a brief bio for Dr. Jeevan Joseph is he's a highly accomplished consultant endocrinologist and director and CEO of Vimala Hospital in Kadyama, India. He holding an MBBS, MD, MRCP, and FRCP from Edinburgh in endocrinology and diabetes. He brings over 18 years of global experience, including senior roles in the UK and the United Arab Emirates. Dr. Joseph has received the NHS Clinical Excellence Award, gold medal in MD examinations from Chennai, India. He is also an active researcher with publications on type 1 diabetes, a multiple Paul Harris, no, and I point a multiple Paul Harris Fellow. He has served as the Rotary Club of Kajam past president, earning the Best Rotarian Award 2023-24, and is the zonal learning facilitator for the Rotary District 3211. So without further ado, Dr. Joseph, please go ahead.
So thank you very much, Rotarian President Tony Layton, and also to the Rotary Club members for your very kind invitation to speak. It's a great privilege and honor to address the members of a very illustrious club. I understand that you've been chartered since 1930, so you're about 20 years older than the Rotary Club of Kottayam, which is my home Rotary Club. And you've requested an interaction on a topic which I think is of great relevance, as your, the introducer to this topic mentioned. And I will try to do a very brief presentation, because I think images will always speak better than words. I will try to be as jargon-free as possible, but I think this being a fairly erudite crowd, I think I might be excused for sometimes bringing in some medical terminology so that we can make the point as well. But feel free to, ask questions at the end of it if there's something that we're not clear about. So can I ask for the sharing to be turned on so that I can share the PowerPoint slides, if that's okay?
Try it now, please.
Okay. Are the slides visible?
Yes, thank you.
Yeah, oh, okay, great. So we'll start off with an image. I don't know if many of you have seen this, and this being a very kind of Zoom presentation, it's difficult to be interactive, but in the comfort of your own homes, just have a look at this image and think what you would make of it. I'm sure that there'll be some of you who think that this is an old woman, and there's probably some of you who would think that this is a young woman as well. I only make this image to drive home the point that sometimes it's important to look at evidence very critically, because you can look at the same piece of evidence and come to differing conclusions. So with that kind of enigmatic note, we'll start off with what is diabetes per se. And I think we've had the historical context to that put forth itself. It's important to recognize that there are two big divisions of diabetes, as it were. Type 1 diabetes is usually seen in children, and it is a case of an absolute deficiency of production of insulin. And it's important to recognize that prior to the discovery of insulin around 100 years ago, a diagnosis of type 1 diabetes was essentially a death sentence. And kids used to probably be put on a starvation diet and possibly used to live for about 4 or 5 years. So I would say that insulin is one of the wonders of modern medicine, on the same par as, say, the discovery of penicillin. Because now people with type 1 diabetes essentially can have a fairly fulfilling and rewarding life just because of the fact that we have discovered and we use insulin as a therapeutic option. But generally, when we speak about type 2 diabetes, we think about the kind of diabetes that you see in people over the age of 40 years, which is also known as the adult onset diabetes. So that's 85% of diabetes is that, and about 10 to 15% is type 1 diabetes, and then you have the rare genetic forms of diabetes, which we will not go into. But it's important to actually put in perspective what test is the best test to actually find out whether you have diabetes. And you can test your blood sugars when you're fasted, or you can test your blood sugars a couple of hours after a meal. But the best test that you can do is actually your 3 months average of what your blood sugars are. It's called a glycated hemoglobin, or an HbA1c. The advantage to that test is that you can do it at any time of the day. It doesn't have to be particularly connected to what meals you've had. It doesn't really change. It's essentially an average of all the blood sugars that you've had over the last 3 months. And a value of around 6.5% or more than that is diagnostic of diabetes. So if you're wondering what's the best test that I can have to find out whether I have diabetes, then I would say that the best test is a glycated hemoglobin. But I'm sure your doctors would recommend the same. But it's important to know that there are different tests with different levels of specificity and sensitivity involved. But generally, people do not recognize that they have diabetes or type 2 diabetes until they've been diabetic for 4 or 5 years. And that's because many of the symptoms that you associate with diabetes are generally symptoms that you could associate with many other conditions like stress, feeling tired, feeling slightly unwell, and so on and so forth. So it's a fairly insidious silent killer. And the importance of the condition is that it's a very common condition. If you look at it in absolute numbers, you have India, which is the most populous nation on earth, followed closely by China, and then you would have all the people who have diabetes. So if you look at absolute numbers, if you put all people who have diabetes in a country, we would be the third largest country after India and China. So I think that, in broad strokes of the brush, is where is the challenge of the problem, because it's a fairly big, it's a silent pandemic, as it were. The importance of recognizing the condition, I think the speaker who introduced the topic mentioned some of the fairly life-threatening complications that you can have with diabetes, and here are some of them. But you can see that it's something that hits across the board, and you can think that this is a fairly benign condition, but at the other end of the spectrum, you can see that lots of comorbidities that you would associate with heart problems, kidney problems, and all the rest of it has its genesis in poorly controlled diabetes and poorly controlled blood pressure, as it were. So I'm going to now take you across to some of the basics of why or what is the big link between obesity, as it were, the explosion of obesity that we see in the world today, and the link between diabetes. So this is from the Nurses' Health Study, and you can see here that when your body mass index, which is a way of actually finding out whether you've too much weight on the body, and you can see when your body mass index is above 35, your risk of developing diabetes is increased almost 40-fold. So you can see that there's a fairly linear progression between putting on weight and becoming diabetic. So one of the reasons why there is an explosion of diabetes is a corresponding explosion in the number of people who, because of dietary problems, their diet, lifestyle, exercise, stress, work, pressures, lack of sleep, whatever it may be, gain weight insidiously over a long period of time, and generally by the age of 40, 45, are in the kind of red zone for developing diabetes. This is actually, again, a medical slide, but I will just run you through it. It essentially tells you the importance of the liver as an organ in development of diabetes. So this was a study which was done in Scotland, and they actually were looking at what is it that might predict somebody becoming diabetic. And you can see that these quartiles of 17 to 21, less than 17, greater than 29, these are all liver function tests. So it's called the ALT. And you can see here that as your ALT levels are a little bit, as they go up, they become higher, your risk of developing diabetes also becomes higher. So generally, just to put it in very blunt strokes of the brush, if there's somebody who's done their SGPT or their ALT levels, and they found that their ALT levels were 40, then their risk of developing diabetes is more than somebody who's of the same age, who's done their ALT levels and found that it was less than 10. So there's a big link between something that's happening in the liver and the development of diabetes. So essentially, the current concept of why people develop type 2 diabetes is that it's essentially a condition of fat deposition in excess in many organs of the body, including the liver and the pancreas, to which some people are more susceptible than others. And so that understanding is important, because it leads us to think about what we can do to make the cycle turn in reverse, as it were, or to put it in other words, what can we do to make sure that we reduce the risk of becoming diabetic? And if we are in the process of becoming a diabetic, as it were, what can we do to prevent that from happening? So the hypothesis that is proposed and is fairly well accepted now is that if somebody were to be losing a sufficient amount of weight, then that can lead to removal of fat from the liver and the pancreas, and this should be able to reverse the cycle causing diabetes, and essentially could even reverse diabetes. Until the last 4 or 5 years, the general understanding was that the diabetes was a kind of a progressive condition, in the sense that once you started, or once you became diabetic, you could control it, you could treat it, but there was no way in which you could reverse it or put it into remission in the way that you might be well controlled and have normal blood sugars without taking any medications. But we now know that that is not the case, and at least in the first 5 to 10 years, there are a significant number of people who develop type 2 diabetes who could potentially reverse the condition and become non-diabetic if they were to lose a sufficient amount of weight. So there was a study that was done in the UK which looked at this. And what they did was that they picked up people who were newly diagnosed with diabetes and put them on a 600 to 800 kilocalorie diet for 8 weeks. So very strict diet on very low amounts of calories. And they looked at magnetic resonance imaging of their liver and pancreas to find out what happened. And you can see here that at the start, there was someone, you can see people who had, all that green is actually liver fat. So you can see on the left here, you have somebody with 36% liver fat. So the whole liver is green with a lot of fat. And when they lose 10 to 15 kilograms, you can see what happens. This is the MR imaging of the same person. 8 weeks later, you can see that the liver is completely black and all the fat has been stripped out of the liver and the pancreas. So, and generally in this study, they found that when people lose about 10 to 12 to up to 15 kilograms of their body weight, they generally become non-diabetic, and they are able to maintain their blood sugars without actually taking medications. Basically the pancreas wakes up. The pancreas is the organ in the body that actually produces insulin, and it's gone to sleep because lots of fat is stored in the pancreas as well. And once you lose a sufficient amount of body weight, you can actually strip out all that fat from the liver and the pancreas. You can make the pancreas work again, as it were, or wake up, as it were. And you can remain in a condition where you don't require any medications to actually control your diabetes, and your body is able to do that for you. The important caveat is that you can't regain the weight, because if you regain the weight, it'll come back. So we don't say that it's cure. The current terminology for it is diabetes remission, which is that you have the condition in the background, but it's as if you don't have it, as long as you can keep the weight off. So this always leads to the general query as to, well, I have Mr. Blogs across the road who's much more of a heavyweight than I am, but he isn't actually diabetic, but I am. And that's a very valid question to think about. And the general thinking at this time in the scientific community is that The reason for that is that every one of us, based on our ethnic risk, what we do in terms of our diet, exercise, and all the rest of it, have something that is called a personal fat threshold, which is the amount of fat that every person can manage without getting metabolically compromised is different from one person to the next. So whilst I might be able to handle X amount of fat, someone else might not be able to handle the same amount. And so there is that differential of why some people become diabetic and others who are of the same BMI or of the same weight don't become diabetic. So there's a little bit of a discrepancy in that. So the only way you can actually find out what is your personal fat threshold is that if you ever were to become diabetic and you are in a position where you're losing weight, and the amount of weight at which you actually become non-diabetic, as I said. So for some people, it's 10 kilograms, some people it's 12, some people need to lose 15 kilograms to actually become non-diabetic. And so you can actually make a judgment of your personal fat threshold in reverse. But there's no technology at this time that will tell you in advance what is the amount of fat or weight that you can put on safely without becoming metabolically compromised. So therefore, it's important for all of us to be closely aware of the deleterious effects of gaining weight and many of the metabolic conditions. So fatty liver, as you can see here, is one of the precursors to somebody developing diabetes. So if you've ever been to your doctors and they've done an ultrasound scan for whatever reason, and they've said that you've got fat in your liver, it's not a very benign condition, as it were. And it could be a precursor to the fact that your body is unable to manage the fat effectively in a metabolically neutral way. And the chances are that if you continue along that path, there's a very high likelihood that you develop diabetes. So everybody that with type 2 diabetes that you do an ultrasound scan, you will be able to see that they have fatty liver. So the key point essentially is that weight loss is key, and one needs to be calorie aware in terms of the kind of calories that we take in. And one of the common queries that we get is that why is it that I do a lot of exercise or I go to the gym for half an hour or 1 hour or whatever it is, but I am unable to lose weight. And that comes back to the key question that we need to understand. So here's a slice of a pizza, which is up here. And you can have a guess as to how many calories there is. I know all of you are muted, so I'll give you the answer. It's around 250 to 300 calories. So if you say that this is 300 calories, you could potentially finish this in you could have the slice of pizza in maybe 5 or 10 minutes. But to actually burn that, you need to walk about 30 minutes to burn up 100 calories. So you're looking at around 1.5 hours of walking to actually burn up the amount of calories that you're going to take in 5 or 10 minutes. So this is one of the problems that we have in our modern day age, that it's very easy to take in calories, but it's fairly difficult to burn them out because the exercises, we've not found a way to actually compress exercises in any way so that you can get more for less. But we found a way to give many more calories with in a much more condensed or dense way, so that it's very easy to actually take them now, and it's very difficult to burn them out. So if you had a burger, chips, and Coke, then you're looking at around 1,200 calories. You're going to have to walk 10 hours to burn it. So if you went to the gym and exercise for 1 hour, you'd still be in a positive calorie balance and you would still gain weight, which is one of the reasons why for all the benefits of exercise, unless you're able to exercise for the majority part of the day, which most of us can't because we've got other jobs to do, it's not possible to actually lose a lot of weight by doing exercise unless we have a control on our diet. So that brings us to the question as to what's the best diet to follow if you were to decide on a healthy way of eating. And generally, what I find very helpful, at least to conceptualize that to my patients, is to recommend what is called the plate method, which is that if you imagine an imaginary plate sitting in front of you and you draw a line through the middle, an imaginary line through the middle, one half of that plate should be vegetables. The other half can be divided into 2 quarters. And in one of those quarters, you can have some starch or bread or, some carbohydrate, and the other quarter should be proteins. So you can see here the importance of balancing out what we eat so that every meal that we take does not add up to all those calories that will get deposited as fat in the organs where you don't want them to go to, so that your metabolic risk becomes higher with each passing meal. I do hope that after this, if you're going to have lunch, that Tony has arranged enough vegetables for you, considering that this is a diabetes talk. We will now move on to the other big complications that we have with diabetes, which is that people sometimes get very glucocentric, which is that they get very focused about the numbers, the blood sugars, and all the rest of it. But nobody dies of diabetes because they've just got high blood sugars. They die because they have many complications from the diabetes itself. And we will start from the top and we'll work our way down very quickly. If you look at the eyes are one of the key issues that you have with people with diabetes, that they have retinopathy or changes at the back of the eyes. It can lead to, loss of vision, bleeding. In fact, it's the biggest cause for loss of vision in the Western world, diabetic retinopathy. So it's very important that you test your eyes at least once a year, and if you have problems, every 6 months. So early detection can save your eyes. So generally, I recommend that on your birthday, you should go and have your eyes checked. If you did have the ability to go and have your eyes checked at any time you wanted. I'm sure that in places like the UK and Canada, perhaps you have a centralized, certainly in the UK we have it, and I'm sure that Canada would also have something very similar, where you have a centralized system or a database in which you get your appointments to have your yearly eyes checked. And, and it's very important to keep that. So you can see here some of the photographs that you can see here. These are also fundus images for somebody who has had diabetes for a long period of time. And you can see all those dots and blots here, which are actually all the changes that have happened because of poorly controlled diabetes. And that you can compare that with somebody who's not diabetic, and you can see how clear the fundus photograph is. And when you see these two side by side, it's easy to understand the amount of damage that poorly controlled blood sugars can do to your eyes. So how do you prevent eye problems if you have diabetes? As I said, regular screening is very important. You also need to make sure that your blood sugars are well controlled. Again, your glycated hemoglobin or your HbA1c, if you were to be diabetic, should be about 7% or less. You need to get your blood pressure well controlled. Most importantly for that is to have a low salt diet. We have ubiquitous and huge overuse of salt in many of the things, especially the processed stuff like canned stuff, burgers and, sausages and things like that have huge amounts of salt. Sugar, again, is extremely, widely used across the board in a way that we can't actually understand in, say, fizzy drinks and things like that, which teenagers now tend to use quite a bit. It's important to recognize that packaging needs to be read to actually understand the amount of these kind of substances in each of these. It's important to have good control of your cholesterol as well. So if you have these big three, which is good control of your blood pressure, cholesterol, and your sugars, with avoidance of smoking and a balanced diet, then you're almost 70% done. So it's not rocket science in terms of what we need to do. It's just that it's not a sprint and it's a marathon. And that's what sometimes gets you out, because if it's a sprint, then everybody's focused and you have to do it for a couple of weeks or 10 days and then you're done and dusted. But with diabetes and many of the other metabolic problems, it's a marathon, and you have to continue what you're doing throughout your life or for a substantial period of your life. And that's where, when other priorities take over, sometimes that doesn't happen, or that gets dropped, or that goes down in your priorities list, and then complications crop up later on. I think the speaker who introduced the topic again spoke about gangrene, and you can see here how diabetes can cause foot ulcers. There are two ways in which it does it. One, it actually reduces the blood supply to your legs so that your legs and the tissues of your legs get less blood, and that leads to ulcers. But also it actually damages the nerves that actually supply the sensations to your legs. And one of the key reasons why people who have normal sensations don't develop ulcers is that you keep shifting your weight because there are involuntary messages being relayed to your brain, and you keep shifting your weight so that you don't keep a lot of pressure on a same area for a long period of time. And if you think about people who have had a stroke and who can't move about, they develop bed sores, and the principle is exactly the same, that if you're in a position where you can't actually sense the pressures that are being applied on various parts of your body, then you might exert excessive pressure for a long period on a particular area, which will then break down. So this is very similar to that. When your sensations to your foot are affected, then you actually don't feel, or the messages are all not correctly wired to your brain, and you can put excessive amounts of pressure on your foot, develop calluses or hard skin, which then eventually break down and cause foot ulcers. So there are two big reasons why people develop foot ulcers in diabetes. And obviously, if you're a smoker, then it actually exacerbates the whole problem, because that can also cause clogging of all the arteries, and that can actually reduce the blood supply to further. So early detection is the key. So looking for sensation loss in the foot. So this is a device that we do use in our clinics to actually look at whether people have lost sensations to their feet, and if they have, then they're classed as a high-risk foot. And you have to make sure that you follow some good guidelines as to how to take good care of your feet, because sometimes we don't take good we take good care of our face, but we may not take good care of our feet. So this is a Doppler which helps you to look at blood flow. But some of the key practical points of to protect your feet is to use the right footwear. So always use footwear. Have a soft insole and a hard outsole. In people who have problems with sensations, use a footwear with a back strap and not a flip-flop, because it will prevent it from slipping off. Many of you would have seen that your feet are slightly more swollen in the evening as opposed to the morning. So therefore, if you're selecting footwear, select it towards the evening hours, because if you select it in the morning and if your feet have a propensity to swell up in the evening, then you might have the wrong size on, and it might be a little bit tight and can rub and produce a small abrasion or a small break in the skin, which could be the entry point for a bacteria, some infection, which can then lead on to other problems. It's important to inspect the foot daily, keep it dry after bath, use a moisturizing cream, and make sure that the small cracks don't appear. And if there is any small blister or wound, you need to take it seriously, because if you have a compromised feet, as in your blood supply to the feet is compromised, or your nerve supply to your feet is compromised, then even a small infection can quickly flare up within a couple of days into a fairly limb-threatening kind of infection, or gangrene, or whatever it is, which will then require amputations and things of that sort. So early treatment, early recognition, prevention, recognition, and early treatment is actually very important. So in all these conditions, the important issue is to hit hard and hit fast, and generally to seek medical help if you feel a red hot foot is always an indication to immediately seek medical help, because there are many conditions where early treatment can help you save the foot. So generally, a pale and pulseless foot is also a problem, and a red hot swollen foot is also a very important problem that you should take very seriously. If you have diabetes, you should seek medical help. Another big problem that you have is diabetic kidney disease. Almost 1/3 of people with diabetes have kidney disease, and it's probably just behind heart problems in terms of why people die from diabetes. And again, it's very important to recognize that if you don't do the right tests at the right time, then you will not recognize this problem. So there are two good tests that can help us to find out whether we are, if you have diabetes, then if you're developing kidney problems or not. The two good tests are, one is your urine microalbumin, which is looking whether there's some protein leak through the urine, and also looking at creatinine levels in your blood that many of you would have heard of, because I'm sure that you've had some blood tests at some point in your career, and a creatinine is one of the tests that we do. But it's important to recognize that doing the creatinine in the blood is not enough to detect early changes in diabetic kidney disease. Because if you just think of it, if you were to donate your kidney to someone for whatever reason, and you had only one kidney, you wouldn't still have a very high creatinine. Your creatinine doesn't go up unless your kidneys are involved by more than 50%. So if you're waiting for your creatinine to go up to actually find out whether you've got kidney disease, then you're going to miss the bus. So the earliest change that you have in people with diabetes is to have leak of proteins through the urine. So it's called, the test is called a urine microalbumin test. A very easy test to do. It's 5 ml of your early morning urine sample to be given into a lab will let you know if you're leaking proteins. It essentially means that the diabetes is affecting the lining of the the sensitive lining of the kidneys, and if you allow that condition to proceed, then that is over the next 5 or 6 years is going to lead to irreversible kidney damage. So it's important to do the right tests, and it's important to understand the science behind those tests as to why they need to be done. We all know about the heart and the mortality that is associated with heart attacks. A leading cardiovascular disease, obviously leading cause of death in the Western world, and increasingly so in the developing world as well. Now that most of the infectious diseases are fairly well treated with antibiotics, and with diabetes, you have a huge risk of having a heart attack, as it were. And it's very important that the basics are there. So if somebody wants to go through a list as to what they need to do to prevent having a cardiovascular problem or a heart attack, good sugar control, good blood pressure control, good cholesterol control, especially your bad cholesterol, your LDL cholesterol needs to be less than 100 or less than 70 if possible. So it's very important to recognize that the numbers are important in this sense, that the numbers are different for people with diabetes as opposed to people who don't have diabetes, because the risk of developing complications are much higher if you are a diabetic. So therefore, your targets are much lower to kind of compensate for that risk. So those three things are important. Obviously, we all know that smoking dramatically increases your risk of having a cardiac event. Exercise is very important, and many people are confused as to what kind of exercises they need to do. General recommendation is to do about 150 minutes over a week, which generally is around 30 minutes of exercise a day. And what kind of exercises do you need to do? Essentially, you need to split it between moderate intensity resistance training and aerobic exercises. So aerobic exercises are, jogging, running, treadmill, cross trainer, swimming, skipping, those kind of things. They're aerobic exercises, but they by themselves are not, enough. And you need to do some moderate intensity resistance training. So, generally a small amount of weights, 1 kilograms or 2 kilogram or 5, things of that sort, dumbbells of that sort, if possible. You can do it, in sequences of 20, exercising the different muscles or the long muscles of the arms and the legs. So it's important to do that because it's important to understand that glucose clearance from the blood, almost 70% of the glucose is actually used by the skeletal muscles when you do exercises. So if you don't exercise your muscles, then it's going to be that much more harder for the body to clear and get good control of your diabetes. You can see that yourself if you are diabetic, and if you do some exercises and then check your blood sugars, they're likely to be far lower than if you were to check it on a different day when you've not had any exercise. So it's important to look at that. It's important to follow a sensible diet, as we kind of just mentioned now. Sometimes people ask, are there techniques that you can do in terms of what you can do to actually prevent weight gain once you've managed to lose some weight. And there are different ways of actually managing your diet. So you can either do a diet where you follow the plate method so that your total intake of calories through the whole day is actually reduced because you are eating more vegetables and things like that, which don't carry calories. For some people, that is doable. If you can't do that, you can do something called a 5-2 diet, which is also fairly popular, which is that on 5 days of the week, you'll do a normal diet, and on 2 days of the week, and those days can't be one after the other. So you can do it on a Tuesday and then you can do it on a Friday, something like that. So 2 days of the week, you'll have a fairly low calorie, low carb diet where your total calorie intake is probably less than 1,000 calories or something of that sort. So for some people, that is quite doable because they can have 5 normal days and the rest 2 days, they'll have it like this. So that over the whole week, their intake is actually less. Or you can do what is called intermittent fasting, which is that you essentially give around 16 hours of fasting through the day. So say, for example, you have your breakfast at 8 o'clock and you have your last meal of the day by 4 o'clock in the evening. And then you have nothing from 4 o'clock except water till around 8 o'clock the next day. That is almost 16 hours of fast. And intermittent fasting can also help in terms of weight control, in terms of metabolic control and things of that sort. So I'm just saying that there are various ways in which you can continue to have something that you like at some points in the day. And the aim of the talk is not to discourage you from having any of the things that you like. The aim is to actually convey that you can have things that you like during some times of the day, but you can't have what you like throughout the day. I mean, some people are lucky to have that, but for most people, if you do that and you have an uncontrolled kind of a diet situation, then that is going to land up in metabolic problems at some point in the future. So I think it's important to recognize that. It's important to also convey that if you do have diabetes and you just started off having diabetes, don't think that it's a progressive condition. There are enough ways and evidence to actually suggest that you can actually cure, in inverted commas. The actual word should be remission. So remission of diabetes is possible, especially within the first 5 years. If you go through a fairly substantial, very low calorie diet program, it's called a VLCD diet. And it's a kind of a diet that a dietitian will design for you under medical supervision. And it involves following a diet so that you take only about 800 to 900 calories a day for about 6 to 8 weeks. Very similar to that image that I'm sure that all of you would remember. And you can see the effect that will have on the fat storage in your various organs. So it is possible to put diabetes into remission and to remain in that remission unless you regain all that weight, in which case it will come back again. So there's new technology for diabetes. We all like new technology. There's new technology for monitoring diabetes. Some of you who are diabetes, if you have diabetes, you would have seen this. This is called the Libre device, which is a small, small 1 pound kind of coin that sized image, a sensor that you can stick onto the skin and will keep continuously monitoring your blood sugars so that you know exactly what's going on. You just scan it and you know what's going on. And your doctor can actually take a printout like this and I'll tell you what's happening with your blood sugars every 5, 10, 15 minutes so that you can look at it and, your medical professional can make a judgment as to whether your blood sugars are well controlled through the day, or are there times when your blood sugars are going low or they're going high. And you can use that technology to actually improve your diabetes control by adjusting your insulin or adjusting your medications, as it were. One of the problems that we've always had with insulin is that we don't like to inject. Nobody likes to inject. And so we want to reduce injections. So we are on the threshold of having once weekly insulins. You can inject it once a week. This is not this is not an insulin. This is a once weekly injection of a hormone called a GLP-1. I'm sure many of you would have heard of it, called Ozempic or semaglutide. It's one of these wonder drugs that's being, the demand of it is so high in the Western world that you can't get hold of it. So it causes a lot of weight loss. It's a completely different agent. It's an injectable, but it's not insulin, and it works in a completely different way to actually augment the release of insulin, as it were, reduce your appetite. It works on the top story on your brain to actually reduce your cravings for food, and generally on agents like semaglutide or Ozempic, you can lose 15, 20, 25 kilograms in weight. Even with the newer one, which is called Mounjaro, which is tirzepatide, can give you weight losses which kind of rival weight loss surgery or bariatric surgery. So there's new technology that is being used. Long-term insulins are available, as I said, for those people who require insulin. Not everybody can get control unless they use insulin. So some people need to use it, but we can actually reduce the number of injections that they needed to take. We can reduce the risk of their blood sugars going low. So technology is always evolving. Even as I speak, perhaps some new technology is being developed. And obviously, there are people who are on the insulin pump, especially used for type 1 diabetes for kids. This is a way of continuous delivery of insulin, so you don't really need to inject yourself. You just have to change the tubing every 3 days. There are also closed loop pumps. So for example, you can wear a pump, and you can also wear a sensor which will be independently sensing your blood, and the pump and the sensor will talk to each other, so that the pump will actually get the data from the sensor as to what your blood sugars are doing, and it will adjust the insulin itself. So it's almost like an artificial pancreas, as it were. So doing what the pancreas would normally do in the body by the use of technology. So the technology is already here where we can close the loop. And if you wear both the pump and the sensor, almost 70 to 80% of the work of controlling your diabetes is automated, and only about 10 to 15% is in your hands, as it were, in terms of giving inputs to the pump. So technology is always evolving. I suspect that in the next 5 years, we will have stem cell technology that will allow us to actually perhaps cure type 1 diabetes, because if you're able to give an undifferentiated stem cell to somebody who has type 1 diabetes, and if it's able to bring about new development of beta cells inside that person, then you could potentially cure type 1 diabetes. There's a recent case report from China where a lady who has had type 1 diabetes for about 40 years is off insulin, having gone through this experimental therapy. There's still, it's not there where we can roll it out to everybody. But I suspect that in the next 5 or 6 years, that technology would have been made safe, and all the side effects and etc. would have been ironed out, where you can actually have that, and you can finally have a cure for type 1 diabetes. So the world is still bright, and there's a light at the end of the tunnel. So the key that I will leave you with is that it's important, whether you're the patient, or whether your relative is the patient, or your loved one is the patient, the key is to have the right patient, to have the right test at the right time. Whether it's detecting diabetes, whether it's preventing diabetes, whether it's preventing complications, doing the right test for the right person at the right time is the key to actually conquering or getting over the mountain that is type 2 diabetes. And the key here is just like, if you have a stool here, you can't, if you have to keep it steady, you need to have all the 4 legs. So you need to have your diet, you need to have your exercise, you need to have your medications when they're recommended, and you need to have your monitoring. And if you have all those 4 pillars, as it were, not just for diabetes, but for any chronic condition, then you can successfully and safely navigate that landscape and come out on top. So with that, I will stop. Thank you very much for your patient listening.
Everything you ever wanted to know about diabetes. We've had it, we've heard it. Dr. Joseph, thank you very much. We're going to get to questions in a couple of minutes here, but first, I'd like to thank you very much for a very clear and a straightforward explanation of what we're looking at, and particularly in terms of what you can do about diabetes and the complications that come with it. You kind of make it
Thank-
clear that the diabetes is not the problem. It is the complications that cause that really are the difficult thing to deal with afterwards. With that, again, on behalf of the entire club, I'd like to thank you very much. And at this point, I think we'll open it up for